that when you give the opportunity to a child to be at the level that he is in his actual maturation, and you just pull him a little bit higher, you get better results. I said that when you get a child and put you in the level of his moment of maturation, and you just pull him a little bit up, the child is happy and performs better, and you have results. So that's, thank you. I like it very much. And well, now we will keep on, we will avanzar, sorry, with the program. Sorry. You know, I don't know. I'm going to introduce you in English. It's my pleasure, and to introduce you a very well-known speakers now and very well friends of the Fundación Querer, Dr. Stephen Wolf and Patricia McGoldrick. Dr. Stephen Wolf is doctor in medicine and fellow of the American Epilepsy Society, is the director of pediatric epilepsy alongside Patricia McGoldrick, which is a nurse practitioner, and she holds a Master of Science in Nursing, a Master of Public Administration, and also a fellow of the American Epilepsy Society. Both serves at Boston Children's Health Physicians in New York and Connecticut, and at Maria Fareri Children's Hospital of Westchester Medical Center, I hope I said it correctly, and are clinical professors at New York Medical College. Dr. Wolf, Chief of Pediatric Neurology, is an internationally recognized expert on pediatric epilepsy who has spearheaded the Level 4 Epilepsy Monitoring Unit and innovative epilepsy care programs across the region. And Mrs. Goldrick leads the Tuberous Sclerosis Complex Program, integrating clinical care and research with over 6 peer-reviewed contributions in neurology and epilepsy. Today, they will discuss neurological, developmental, and psychiatric issues in children with epilepsy. So welcome, Dr. Wolf. Now, yes, please, this applause.
Thank you for having us. Patty and I are honored to be here.
We want to particularly thank Pilar and Alfredo and Eugenia and Susanna and everyone that we've worked with for so many years, and thank you for continuing to invite us back. Oh, we have a clicker. I'm usually really bad at this, so let's see.
Since the school has a number of children with epilepsy, we thought it'd be really worthwhile to discuss some of the issues that these children have, and so we thought we'd go with a little review.
We talked about this a little bit about 3 years ago, and this is an expansion of what we had focused on. So just to, we're not going to do as great and wonderful a basic level as in one of the previous talks where there was talk about the cells and the synapses, but we're going to talk about epilepsy and its impact. Epilepsy is a lot more common than people think it is. It affects about 65 million individuals across the world. The sad thing about epilepsy is that it is not, we're not able to control the seizures as well as we would like to. So only in about 60 to 70% of people do we manage to quiet down the seizures so that they don't have to worry about it. So that leaves a large group of 30 to 40% that still have uncontrolled seizures. And of that group, of the group with epilepsy, there are frequent comorbidities, so other issues that go along with the seizures. So we often say it's not the seizures that are the issue, it's the other issues. It's the learning disabilities, it's the psychiatric issues, the mood disorders. There's a big incidence of headaches and migraines in people with epilepsy, cerebral palsy, movement disorders, sleep problems, either sleeping too much or not sleeping enough. Mood issues, depression, anxiety, attentional issues, attention deficit disorder, and then the medical disorders that go along with it. So diabetes, cardiac issues, and obesity.
So talking about the incidence, clearly you're looking at 41 to 80, 187 per 100,000 patients developing epilepsy.
It's children.
And that's in children. The prevalence is, pretty significant, almost like 4 in 1,000 patients in developing countries. So we're seeing this in rural areas, we're seeing this in city areas, but the diagnosing is really important, and getting these children to treatment is extremely important because it's pretty prevalent.
It seems like there's a higher prevalence in rural areas, and I'm not sure what that's attributed to. It can be accidents, farm accidents, that sort of thing with head injuries. We don't know, there are a lot of different kinds of epilepsy. We shouldn't be treating it as one disease state because there's all different manifestations. And the problem with really reporting the numbers is that there are so many different types.
But there is frequently a delay of diagnosing epilepsy in some children. Thank goodness a lot of the teachers pick it up before the parents frequently pick it up. But most of the time there is some delay that one episode will happen, no one will know exactly what's going on, and then eventually they'll get diagnosed with an EEG and they'll get eventually to see a neurologist. So in countries, and there is a shortage of child neurologists across the world. These are many of the causes of epilepsy, so it can be broken down into a few different groups. One being structural, meaning the brain itself did not develop properly or is not formed properly. And there are a list of simple things such as head trauma, where if you injure the brain, or a stroke, or abnormal blood vessels such as cavernomas or subarachnoid blood, scarring of the brains cause something called hippocampal sclerosis, which might be developmental or actually might be post-infectious in some patients that we've seen. Of course, brain tumors, all these things can affect how the brain is developed and can cause seizures. There are even some infectious diseases such as viral meningitis, bacterial meningitis, that can cause seizures because they injure the brain, sort of like head trauma. There are genetic stuff we'll talk about on the next slide. And there are now, we found some immunomediated reasons for causing epilepsy. There are some basically what we call autoimmune diseases, such as unusual antibodies, such as NMDA is one of them. This is something new. And we are just learning this. There were many children that we took care of that had terrible seizures, and then we found that they had autoimmune antibodies. And you guys have heard of diseases such as lupus or rheumatic arthritis. These are autoimmune diseases. Then there are ones that just affect the brain. And this is a whole new world that we are just learning. And then there are some of the metabolic and other genetic disorders. Maybe you've heard of maple syrup urine disease. It's one that's picked up in the newborn period, but there are a whole slew of these different disorders that can affect the brain and cause seizures. So there is a whole potpourri of different causes for epilepsy. And again, the important thing is treating it and understanding the etiology, why it's happening, to help better treat the epilepsy.
And that whole graph is another reason why we don't have great numbers about the incidence of the different kinds of epilepsies, because there's so many different causes, and you're trying to track one specific cause with the outcomes. And then we get onto the genetics.
Now, the whole genetic world is changing rapidly. When Patty, myself, and Antonio, our colleague here in Madrid, started 10 years ago, there was maybe 1 or 2 tests that we could send. 5 years ago, we could send for 100, and now we can send for 20,000 different genes. And we're sort of looking at our children going backwards, and we're finding more and more genetic disorders. And you already heard this morning about 230 different genetic disorders that are associated with epilepsy. With autism. This morning it was more autism. And so what you're seeing is a whole, what we call alphabet soup of genetic disorders that are associated with different parts of epilepsy. And you can see that they affect the pathophysiology. It's all the different things that these abnormalities affect in making the right proteins to make the brain develop properly. And it could be affecting things such as sodium channels, potassium channels, receptors, alpha subunits, all this mumbo jumbo of weird little different things that are needed to make your brain develop and work properly. And not only that, but we see a huge overlap with our patients with epilepsy and autism. And in fact, we know there's about 100 of those different genetic disorders that have autism and epilepsy together.
All right, so the thing that we have to weed out, and which is hard to do, is are the comorbidities a function of an abnormally formed brain at the cellular level? So if you think of those neurons, are they abnormally formed or is their function abnormal that we were talking about earlier? So has something affected that? Or is it the discharges, the abnormal electrical discharges that cause the seizures? Or, on the other hand, is it some side effect of the medications that we're using to treat the epilepsy?
Or a combination of all three.
Right. So we have to know as much as we can about the patient. So that's why we do MRIs and we do EEGs and we do genetic testing so that we can try and figure out how to treat most appropriately and use precision medicine. This is the disease course, and this lumps together 400 kids in the Netherlands, and they looked at them with new onset epilepsy and then studied them for about 15 years. And what they found out was that not everybody had the same course, so not everybody got better. So there's a refractory, which is a pretty stable, talking about development and seizure activity. There's another progressive where they get worse over time, and then there's a remitting. If those of you know about multiple sclerosis, this is sort of the same thing. You have a remitting and relapsing. They get better, they get worse. Or they get better, but they have a bad time at the start. So you can't tell what path, for the most part, you can't tell what path the child is going to follow at diagnosis unless they have a genetic abnormality or structural abnormality.
And this happens when we're taking care of our children. We ask them how their epilepsy is doing. That's the first thing we ask. And then the next thing we ask is how they're doing in school. And hopefully we see that there's a good progression, but many times the parents will say, the epilepsy is under control, but their learning has taken a dive. So then we have to be detectives to try to figure out why. And as Patty said, is it from the medication side effect, or are there subclinical seizures happening at night that we're not seeing? Or is this the underlying disorder and just academically it's getting harder? So playing detective and trying to figure out where we are on the curve is the art of the game of what we're trying to do, and it's very difficult.
And this is also where the whole team comes in. We were just talking about that before. We need the teachers, the parents, we need the siblings, and then we need the medical team. So we all have to talk to each other, and as time goes by, there's less and less time to do that and to really function as a team and talk to each other. In the United States, what's happening now is that the people who treat the epilepsy don't want to treat the comorbidities. And as we get fewer and fewer epileptologists who treat epilepsy, it's a big challenge to the children to be able to treat for everything. So we have to be very cognizant of that and to look at it from a more holistic perspective, and then to talk to the other people involved in their lives.
So imagine someone comes in, their epilepsy is well controlled, and now they have a regression. And your job is to go through this list of other possible comorbidities. Could they be affecting the child and causing the regression? Is the child undiagnosed and actually is on the autistic spectrum, having more anxiety, having ADD, having depression? Is there a missed learning disability here? Remember, this is an evolving child. You can't diagnose this when they're too young. Motor issues, sleep, and feeding issues. And we're going to sort of try to dive into this quickly.
All right, so this is the prevalence rates of the psychiatric comorbidities only in children with epilepsy. So if you look at the prevalence rate, on the right is the general population, and on the left is children who've been diagnosed with epilepsy. So depression in the general population is anywhere from 3 to 17%. In the children with epilepsy, it's 11 to 50%, a much higher incidence of prevalence. Same thing with anxiety, 15 to 25% in those diagnosed with epilepsy and only 5 to 7 in the general population. But that is from 2007. That rate is much higher now. I think everybody got way more anxious over COVID, and it's really affected our kids and the rest of us. Panic disorder is higher. Attention deficit disorder, much higher, almost 3 times higher than the general population. And then there's psychosis, which doesn't figure that much.
So we know that the earlier the epilepsy starts, the worse the cognitive problems are. And so this is that we saw from data from our colleague from Chicago. It's sort of pretty obvious. You start having seizures earlier, you're going to have more cognitive impairment.
So this is the percent of patients with an IQ under 80. So if they start having seizures, if they're diagnosed under the age of 5, about 40% of them will end up with an IQ less than 80. If they're diagnosed from 5 to 9, about 15%, and over 10 years old, about 13%. So worse outcomes cognitively with an earlier diagnosis.
So we know that the etiology of why someone has a seizure, meaning was it brain damage, is it a bleed, is it something genetic, will clearly affect the cognition. We already mentioned the age of onset of the epilepsy, the type of seizures. We know that people have drop seizures, or otherwise known as atonic, or what's called tonic seizures, are more cognitively impaired than kids with focal seizures for some reason. And some of the other hereditary, psychosocial, all these things combine together to affect the cognitive development.
So the kids who are most at risk for the comorbidities are those who's they're having seizures, but their EEG is abnormal all the time. If they have a lot of activity on the EEG, a lot of spiking, or if they have an abnormality that continues all the time. Those who've regressed, so if they have gotten worse over time, their motor skills, we just heard about motor skills, if the motor skills have gotten worse, or if their social interactions or their academics have gotten worse. Those who have an abnormal MRI, so they have a structural abnormality, are more at risk for cognitive issues. Those with absence, so absence are the staring spells. So if you think about it, if you're having a staring spell that's happening a few times an hour and it's lasting 30 seconds to 4 minutes, you're missing a lot of time that you're being taught something. So you want to get them under control. Those who are on medication for seizures have more cognitive issues, and those who have, we call them pharmacoresistant seizures. So those are the ones, sometimes we'll see children who are on 2 or 3 different medications. So using more than 1 or 2 medication also causes worse cognition. And what we try to say all the time is if we can get the seizures under control and they're not having seizures, the cognition will get better. But sometimes if they're on 3 or 4 meds, maybe the cognition is not getting better because they're so tired from the medications.
So there are these other developmental epileptic encephalopathies. This is a group of children that have a very abnormal EEG that we already described. They have extreme developmental delay, and they have a lot of other cognitive issues. And there's a bunch of them that are classic names. Dravet is a clear genetic disorder that has what's called an SCN1A mutation. Lennox-Gastaut is a big group of lots of different etiologies, but yet their EEGs sort of look the same, which is sort of odd. So the brain obviously has been affected, and the EEGs look the same. They all have developmental delay, but every single kid's different. And then tuberous sclerosis is a clear genetic disorder, but it too falls into this category of severe epilepsy, severe developmental delay, cognitive impairment. So we have a lot of these kids sort of grouped together, and they all can have this mixed potpourri of cognitive issues and comorbidities that we're going to talk about.
But that is not to say that they're all terrible if they have those diagnoses, because there is a continuum from not very much affected all the way to severely affected. Sometimes you'll say to a parent, your child has Lennox-Gastaut or your child has Dravet's, but even in our practice, we'll see some children within those categories that are functioning fairly well, and we'll see others who are severely affected. So you have to be careful what you say to the parents.
So we mentioned already the idea that there is a high risk of autism with epilepsy. We see about 20 to 40% of children with autism will actually have epilepsy. And they can develop epilepsy at any age. And there's sort of 2 bumps. Bump is an early elementary age, and then in puberty age is a second bump of incidence. So this is an unfortunate but common consequence.
We also make a point, there's another conversation I was just having, to tell parents who come in with children with autism or a language delay to be aware that they may develop seizures at some point, so they're not taken completely by surprise as the child gets older.
So testing is important.
And, in the United States now, we have very little ability to test for autism. It's really very, very difficult at the moment. Our institution just instituted a program for children under 3. The pediatrician can send them for a specialized, faster diagnosis so that they can get the services younger.
So there is, again, we mentioned the genetics of autism and epilepsy. We're learning all about this. There's something going on at the molecular level. We're just not smart enough yet to understand it. So we're going to learn together, hopefully with some of the scientists here. if we can get them some more brain tissues, right? We were talking about, you heard a little bit this morning about signaling and plasticity and disruption of connectivity and GABA. This is just to make the other scientists reiterate exactly what everybody was talking about this morning, like from Dr. Rico. But this is what's going on deep inside the brain that's causing our problems. I think we can go on.
Yeah, we've talked about this. All right, so depression. Depression doesn't always present itself in childhood the same that it would in an adult or in a child who's minimally verbal. It's not like you're going, I was amazed when I started school and somebody said to me, the way that you ask about depression and suicidal ideation is you say to the patient, do you want to hurt yourself or kill yourself? And then they say, yes. And then you say, well, how would you do it? And they would say, well, I'm going to jump out of the car on the bridge. Or there's a knife in the kitchen, I'm going to kill myself. I never believed that anybody would ever say that to me until it happened. And I said to a kid, do you want to hurt yourself or kill yourself? And he said, yes, and I'm going to jump out of the car as we go over the bridge on the way home. And the mother said, yes, and he will absolutely do that. And I was blown away. I mean, this is not that long ago. So, but our children, so if anybody says that, that's exactly the way you ask, and that's exactly the way they answer, and then you send them immediately to get help. But a lot of our children are not able to verbalize that. So you have to look for other signs. So are they tearful? Are they upset? Are they angry? There are screening tools, which I'll talk about in a minute. Up to 20% of children with epilepsy report suicidal thoughts. You're never going to know that unless you actually ask the question. In the majority, they think things like, I'd be better off dead, I shouldn't be alive. But there's a big percentage, 4 to 11%, who said, yes, I do want to hurt myself, and yes, I have a knife, or yes, I asked this question the other day, and I said, is there a gun in the house? And they said, yes. And I said, we need to get rid of that gun very quickly.
But in our special needs population, it could be a regression. It could be that happy child that used to walk into your classroom is now no longer happy, and you need to sort of dig and sort of find out what's going on. So it's like playing detective. It's really hard.
And these are the symptoms. So depressed, irritable mood changes lasting, for every day for a couple of weeks, not doing as well in school, sleep issues, sleeping more, sleeping less, agitation, regression, the ones that used to separate from their parents when they dropped them off at school and now are clinging and attached to your leg when you drop them off. And then nonspecific, stomach aches are a big one, headaches are another one. As they get older, sleeping more, gaining and losing weight, and then the irritability, and also substance abuse in the older ones.
We've had some parents come in and say that the kids are just not sleeping at all at night, or they don't want to go to school and used to go to school. We've just seen so many different clues, and again, frequently have to talk to the teachers and sort of try to tease it out and see if that's what the underlying problem is. And if there's a family history of depression, that also might be a clue, because the depression can be genetic, and even though the child is on the spectrum, doesn't mean they're not going to be affected.
And then the same thing, you have to talk to the child and the parents separately, to both parents if they're separated. And then we use these screening tools, so you have to do repeated screening tools. The other thing is that you have to weed out whether it's the medication. Some of the medications that we use to control seizures are notorious for having a side effect of cognitive issues or depression or anxiety. These are the treatments.
There are a lot of treatments. We're not going to go into them. There's cognitive behavioral therapy. There's some self-regulation skills.
Getting them in to talk to someone is really, really important. And assume it's the same in Spain. We don't have enough counselors to go around. We have counselors, we have social workers, we have advanced practice nurses who do a lot of this, and then we have the usual psychologists. We send them to the school. Kids may not want to go to the school to get counseling. They may want somebody outside, and there's a big shortage of child psychiatrists.
Medications.
And then we treat.
There are, but cognitive therapy is the first step. But as Patty mentioned, it's lacking. But there are medications, and we can use all the common medications that we use in the normal, typical population. Even if they do have epilepsy, there is a very low risk of worsening the epilepsy. Now, just talking about our anti-seizure medications.
It's just before, as an intro, the big thing that we're dealing with now, as I said, many of the epileptologists don't want to treat the comorbidities. So it's important for the people who are treating the seizures to know which meds to use with which comorbidity. Now you can continue.
Thanks. She would like to have a mute button on me sometimes.
I'm going to make this into
But in 25 years, she hasn't figured out how to do that yet. So of the medications that we use, some of them do have a benefit and some of them do have an impairment. So we know that there are some medications that actually can help mood disorder that we use for epilepsy, such as lamotrigine, oscarbazepine, even valproic acid. And then there are some medications that actually can worsen it, such as levetiracetam and topiramate, that actually can worsen it. So sometimes we'll have a kid come in, they'll have seen some, rural neurologist, and the kids are bouncing off the wall, and we're like, what medication are you on? And it's levetiracetam. Like, I think it's time to take the medication off. But it can be this kind of behavior can subtly kick in. So you got to really sort of dig in there. And you can see for anxiety disorder, there are ones that are good and bad. So where lamotrigine was good for some mood, might not be that useful for anxiety, cognitive impairments. We know that like lamotrigine is actually very clean, but topiramate is actually can really slow you down, or our nickname in America is Dopamax. It can dope you up and slow down your brain. So these are important things to sort of think about and try to look at the child in a big picture and not just focus only on the seizure count. This is our talk to our fellow neurologists frequently.
And sometimes somebody came in the other day and the child had gained a ton of weight, and the mother just said he can't be on these 2 meds anymore, and we ended up doing surgery on him. But it's important to realize that if the comorbidities are that bad, then we have to look at something else. All right, and these are side effects of the epilepsy meds, long-term effects on attention. There's fewer studies. There are few studies that measure both the comorbidities and the medications. The newer ones we think are better, but the problem in the States is getting the insurance companies to approve the newer meds is difficult. You just have to start with an older one, and then you sort of have no idea if the newer one actually would have worked better had you used it earlier on.
We mentioned some of these medications and some of the benefits and worsening. In the middle is cannabidiol, which I know is not available here. This is the medical marijuana derivative of just pure CBD, not THC, out of marijuana. And we've had a lot of experience in America using this for epilepsy as well as some mood and behavior and having some benefits. Though I think it is available now.
With with clobazam.
Antonio? It is available now.
If you use it with clobazam.
But used with clobazam.
Yeah.
And so there's been a lot of benefits in using it.
Oh, you can do
With
it
and without now?
Oh, that's
Oh,
cool.
see, we're not
That's
even
different.
up to date. See, you guys are flying past us. So learning disabilities and epilepsy are a big issue. So again, you need to screen and to look for it and treat it. And your schools do that, obviously.
And there's never enough schools. In the United States, the problem is that everybody with all the different disabilities are grouped into one group. You go to a central school. It's not personalized learning. And I was just having this conversation that not much has changed. My oldest child, who's now 34, it's the same thing that was going on when he was 3. So not a lot of stuff has changed. And there's never enough schools.
Attentional issues, trying to diagnose attention deficit disorder. All us men have attention deficit disorder. Again, the rule of thumb is if it's functional impairment, if the ADD, the attention is so bad that they can't achieve academically or socially, then you should consider possibly trying medications. And there's not a contraindication in using it in patients who have epilepsy.
There's no real sex difference in the comorbidities except for ADD, except for attention deficit disorder, where it is as common in girls as in boys with epilepsy. In the general population, it's more common in boys, but that could also be a testing phenomena, that girls are not diagnosed until later.
So we know that patients who have poorly controlled seizures also have a higher risk of dying. There's something called SUDEP, or sudden unexpected death in patients with epilepsy, and so this is very frightening. So it's very important that we do the best we can to get the seizures under control to prevent this from happening. It's an unfortunate consequence.
And that we educate the parents so that they know about the risk.
Suicide?
The same, it's small but significant. 11% of children with epilepsy will attempt suicide, and that's why we use the screening tools. There's a couple of different screening tools that are listed up there. large under-recognition of psychiatric problems, and that's what Steve was talking about, that you don't just ask about the seizures, you ask about the other things. And it's important to also ask the child, because sometimes the parents will say everything is fine and everything is not actually fine. And we should all be screening, not just neurology, not just epilepsy, it should be psychiatry, it should be education. These are the free tools. There's a depression scale, a depression inventory that has to be administered by a mental health professional. But this NDDIEY, it's a self-report that it's supposed to be filled out by the child, which is important. You don't sort of hand it to the parents when they come in, because then the parents fill it out. It's a little bit of additional time, but it's certainly worth it. This is neuropsych. Somebody else talked about neuropsych already, but that's the testing that's done in the neuropsychological evaluation. And that's the screening tool. This is what's handed to children. It's ages 12 to 17. So it's a quick checklist, and then that leads you to have a conversation with them.
We haven't figured out the exact best way to get it done in our office, whether we should take the kids separately and have the medical assistant help them to do it, or the parent to do it. So again, trying to figure out how each kid has to be sort of done differently.
You can.
So the bottom line is, when you meet as a provider, the patients, to try to tease out what's going on and ask all the questions about the seizures, looking at medication, how they're doing academically, is there aggression, is there progression, what's going on behaviorally, at home, at school, what's going on socially, which is really important. Evaluating their attention, which I guess is really sort of feedback from the school as well as from the family. Sleep is a really important thing. That's the one thing that we find the most often not asked when talking to families. And again, looking at the whole quality of life for the child. So we really try to teach our providers to sort of look at all these different aspects when looking at a child with epilepsy and trying to understand how the comorbidities bring it together.
All right, this is integrating psychiatric and neurological care so that the neurologist adapts more of the psychiatric issues and managing the concerns.
It brings back the idea that it takes a village to raise a child. It takes a village of medical providers and academic providers to sort of do the same thing. And as you can see,
it's funny now when we talk about how it affects the family life, the newer drug studies that are coming out are not asking just is there a reduction in seizures with the new medications? They're also asking things like how many days did the patient go without a seizure? So if you think about that, that's the family being able to go out and do activities without worrying about having a seizure and missing that time. This is the International League Against Epilepsy guidelines, so routine mental health screening, looking at work infrastructure. Okay, this is the conclusion. Look, see, we're right on time.
So the bottom line is, recognize the different comorbidities, ask all those important questions that are outside your box. Whatever role you are providing in this child's village, give feedback to that family so they can give feedback to whoever the team leader is. And the bottom line is, we have a lot more research to do and a lot more things to understand, whether it's from the new medicines or from screening tools or from understanding down to the etiology. Sometimes our children aren't fully worked up and they actually don't have a clear diagnosis and they need further evaluation.
And then also to integrate music earlier on, to integrate more structured school at a younger age. There's a big dearth of people who can do early intervention. And
we want to say thank you.
That I got to the end. Questions? Oh, it'll be over there. Okay. Anybody have any questions? Yes.
I haven't grasped really, I don't know if you've mentioned it, but has epilepsy reduced in this?
Has the incidence of epilepsy
Yes.
No, not at all. And the incidence of people with uncontrolled epilepsy has not changed over the last 30 years, even with all the new meds.
Okay,
Nope.
that's really scary, actually.
Yep, it's terrifying.
So you're specialists in epilepsy, right? So do you wait for the seizure and then access the comorbidities, or do you, because I think it's important to maybe it's something that I think that maybe the comorbidities are causing the epilepsy. Well, you're the specialists, but do you first wait for the seizure and then
It depends on what comes first. You might see a child who comes in because they're having a learning issue or autism, and then the seizures come later. So you address whatever comes first.
right?
So if they're having a learning issue, you address that, and then perhaps they have seizures down the road. If they have seizures, you address that, but then you're very aware that all these other things can happen. So you make sure that you're proactive, that you are in advance getting testing, making sure they're not having any difficulties in school, and as Steve said, asking all those other questions.
So, but it's a really good question. So now that we have genetics, we know there are some genetic disorders that will cause epilepsy, and they can develop autism. So for example, tuberous sclerosis, TSC1 and TSC2, we can diagnose when they're a baby, before they have epilepsy, and before they look like they're having autism. And there was a study that we did looking at babies, and we started doing EEGs literally as soon as we made the diagnosis, and every 6 months doing EEGs. And then when it becomes abnormal, we looked at babies that we started anti-seizure medication before the EEG became abnormal, and ones on the day that they became abnormal. And then we followed their development over the years. And what we're trying to decide, it's called the PREVENT study, is do those children, does it decrease the risk of them developing autism or decrease the risk of them developing seizures? And that data is still coming out, but that's exactly what your question is, can we prevent it? We're not smart enough yet to know, but if we could diagnose all the genetic disorders early, maybe we can. Does that answer your question a little bit? So we're not there yet. Maybe in a few years you'll come back, we'll have that answer.
Very interesting and complex work. My question is related with so in the cases where you don't have any, it's only epilepsy and you don't have any developmental comorbidity or event alterations in the EEGs, I guess, because we, as biologists, neurobiologists, we ask always this question, so what is first and what it costs one after the other, we don't know what is happening. So I just wonder if it's only epilepsy and the medication that you use for the epileptic seizures stopped epilepsy. So is there any window of time where this reverse is no longer possible? I ask this question because from the developmental point of view, with all this activity going on where all this wiring is happening, I just wonder there is a time where this reverse is not possible and there is also failures in the full development on connectivity that is an addition of these epilepsies.
So there are some epileptic syndromes, and I think it depends on the etiology, that that child will have seizures, will have comorbidities. You treat the epilepsy well, and they actually improve and do better with their comorbidities. And then there are some, when the epilepsy starts, that they develop a lot more comorbidities. And even when we change the medication, they might be there as well.
But what we're coming out with now is more disease-modifying treatment options. So for Dravet syndrome, there's new treatment options that are coming out now, and we're hoping that there will be more of them, so it will alter both the disease state of the seizures and the comorbidities by changing the gene.
There's a new gene therapy, an ASO, antisense oligonucleotide, to treat this genetic disorder, and they're seeing that these kids cognitively are doing better and they don't develop all the comorbidities. So it'd be very interesting. Yeah.
Wait, Alfredo are you telling us to stop or do you have a question? Okay.
Okay.
Yes.
Thank you, great talk. And I'm really glad you mentioned sleep. In San Diego, a lot of the really young kids we see, we do the MRI while they're asleep at night, natural sleep, and so we ask the parents about sleep a lot. And it has really crystallized out as one of the main concerns of a lot of families that really impacts daily life and functioning of the child. And based off our results, it's very much related to a lot of the core symptoms we see in autism and neurodevelopmental disorders. So, and it's very much under-addressed, I think. So I'm just curious what you do to follow up or track sleep issues in these kids and how you treat those.
So we asked the question. To us, we know that you lay memory in sleep. Those of you who get woken up multiple times a night, you know you're not remembering as well. So that obviously we think that affects the children. We actually treat the children with medication if they're not sleeping properly.
Yeah, we do the, the bedtime regimen, the usual things that I find that this doesn't get passed down from generation to generation as much anymore. So, a bedtime routine, no electronics in the bedroom, and then we treat with medication, and we start with melatonin, and then we go through to real medications for sleep.
But simple things like obstructive sleep apnea, snoring, those things need to be addressed as well with the pediatrician.
I think it's very interesting, this point of mental issues.
Yeah, they can't hear you.
Oh, I appreciate very much this speech about comorbidities in epilepsy, because many times you are so atomicized that you just look at the EEG or anything else, and so I think it's been grateful. And I would like to stress for non-medical public here that some clumsy behaviors that may not make you think about emotional issues like angry, you mentioned it, or like being a little bit doing jokes all the time can be.
Anxiety symptoms.
So I would like to stress that. Me gustaría decir que hay cambios en conducta que no parecen depresión o no parecen trastornos emocionales, y para el gran público creo que es importante saber que, por ejemplo, en los varones la agresividad puede ser un síntoma de depresión en edades tempranas y en la adolescencia, y también puede ser el tipo. Hago muchas bromitas sobre todo es irónico y puede estar detrás, si algún psicólogo en la sala quiere corregirme, pero lo digo como cosa de gran público, si estos comportamientos aparecen y no estaban, pues una alerta. So,
And then the same good, great communication and sending us notes and telling us what to write if we're asking for more services is really helpful.
yeah, you're right.
Thank you.
Thank you very much. Thank you.